All right, Tom, I hear what you mean by saying it feels so good to stand up. So I will start with surgical advances. We all have been taught that the standard treatment for 1A2 to 1B1 cervical cancer is a radical hysterectomy with pelvic lymphadenectomy. But are we too radical? So acceptable alternatives to radical hysterectomy that I'm going to be talking to you about today will be simple hysterectomy with nodes or minimally invasive approaches. So in a low risk group, when you look at these studies, you can see that the risk of parametrial involvement is less than 1%. It's 0.3%, which brings us to Dr. Schmaler's trial, the CONSERVE trial, which was a prospective cohort of low-risk cervical cancer patients, 1A2 to 1B1 with small tumors, less than 2 centimeters and less than 10 millimeters depth of invasion, with no LVSI, and a cone with negative margins. Prior to the treatment, she noted a 5% positivity of nodes and a 2-year overall recurrence rate of 3.5%. And Dr. Plant looked at the SHAPE trial, which was recently presented at ASCO, and I think is a very compelling trial. And her hypothesis was to evaluate whether less radical surgery with simple hysterectomy could be associated with similar efficacy and less surgical morbidity compared to radical hysterectomy in patients with low-risk disease. And this is the schema for the SHAPE trial. And again, I think it's really important to focus on the criteria, which for low-risk cervical cancer, which was defined as a 1A2 to 1B1 with less than 10 millimeters stromal invasion on a diagnostic biopsy, LEAP or cone, with less than 50% stromal invasion on MRI, and size not greater than 2 centimeters. These patients were randomized 1-to-1, radical hysterectomy or simple hysterectomy with lymph node dissection. The primary endpoint was pelvic recurrence rate at 3 years, and this trial did meet its non-inferiority cutoff, and this was a really impressive trial, 700 patients, and it showed that surgical adverse events were lower with the simple hysterectomy, both acute and late complications, and especially when you look at the incidence of urinary incontinence and retention, both of those were also reduced. In addition, quality of life and sexual health were improved with the simple hysterectomy group, and both of these are really important since these patients that we treat with cervical cancer are young.
So can I ask you a question? Can you go back to that last slide? I mean, that's like that's a wow moment, because I don't think I've ever seen a table where every single p-value is less than 0.05. And just the survival curves and the way that study was done, I just wanted to ask you, what are you doing in your practice now? Have you changed your practice due to this data?
Yeah, I think these data are really compelling, and I think it's time to change. This was a study that took years to complete. It started in 2012. It was a 700-patient non-inferiority trial where we've shown quality of life improvement.
Yeah, I think another important aspect to take into account here is the very stringent inclusion criteria. And I'll be honest, I don't typically do MRIs on all these patients. So I just wanted to have this query you all. Ramos, have you changed? Were you always doing MRIs before, or what do you do now, and what do you recommend for other providers?
This is such an important question. I always get pre-op MRIs on a cervical cancer patient that I'm considering surgery on, and it's with contrast, and our institution actually does, as long as the patient is accepting, and it's not an issue, but they do intravaginal gel to help with visualization of the lesion in the cervix, and also to help adjudicate whether or not there is truly vaginal involvement or not, which can be more difficult to interpret. But yes, I personally will always get an MRI before surgery, and like you mentioned, the eligibility criteria for these trials mandate it. So it's so important that when we extrapolate this to practice, we do the same thing so that we're not going to inadvertently harm patients by doing the inappropriate surgery.
Yeah, I still think it's really important for the GYN oncologist to be evaluating these patients and deciding what's the appropriate procedure for them. So the audience members, how many of you have changed your practice and are now doing simple hysterectomies for these specific patients? Anyone? Or are you still doing radicals?
Dave? Yeah.
But yes, you'll change. Okay, awesome. That's what I'm just checking.
Give me a week.
Well, it's been maybe 2.5 weeks. All right. All right. Well, now I got another big question for you. How are the results from SHAPE going to impact the ROCK trial?
The perfect segue, because I'm going to talk about the role of minimally invasive surgery. So we know from retrospective non-randomized trials that there's been no difference in oncologic outcome between MIS and open radical hysterectomy. But the LAC trial challenged that and noted that the disease-free survival at 4.5 years was lower with minimally invasive surgery at 86 versus 96.5%. And so this has led us to really definitively look at some of the potential shortcomings in the LAC trial, and that is namely to not have a preoperative MRI assessment for tumor size, as well as really utilizing containment methods for tumor during tumor removal. So I hope that all of you have this trial open. It's a great trial. It's a randomized trial of robotic versus open radical hysterectomy for early stage cervical cancer, and the primary outcome is 3-year disease-free survival. So if you haven't opened it, please do. We're very excited about it. I'd love to hear what Dave has to say about how you think it's going to impact.
Well, Kristen Bixel, my partner at Ohio State and James, is the lead investigator here. So we've talked a lot about this. The information's just getting out, so I think we need to look to see what the enrollment happens here. There are discussions that will we amend this trial to allow for those patients. The question then becomes, are you doing a mini laparotomy, simple hyst on those patients? But I think is very reasonable. It was interesting. I don't think you showed it. The sub-analysis of the MIS that she reported at ASCO had a numerically about this. Well, it's actually numerically the same, but there's greater numbers. So, I think that question of containment will still apply even if we do a simple hyst. So I will still continue to enroll on ROCK. If it's amended, then we will talk about even doing mini laparotomies for simple hyst with sentinel nodes.
Yeah, I think that's really important. Can I just say, just to clarify, because I don't know that everyone followed what you just said. In the SHAPE study, in a subset analysis, is not statistically significant. There were more extrapelvic failures in the MIS group, because a lot of patients on SHAPE had MIS. It was like 70%. So there is a sense that there's still a problem. This study, even if it's amended,
and that's
will
a lot of
answer
data
that.
sets to ignore now.
Right. So it's important still to do this and not just flip to laparoscopic vag hysts or TLHs. I think that's really a key thing to say, that we're not just giving permission to just do whatever here.
Correct.
Right. That trial was not addressing minimally invasive surgery. Right.
This one does.
This one will, and
Correct.
it's an important question that we
So
still
it's
need
very
to
important
answer.
that it continue. Yeah.
So what is wrong with a laparoscopic nodes vaginal hysterectomy? If it's simple hysterectomy suffices, why cut her open? I thought, I mean, at least I still do vaginal hysterectomies. What's wrong with that?
I think the issue is the containment.
It's coming, there's no containment. I remove it through the vagina.
You were doing that with the robotic radicals too.
Do you really still do vaginal hyst?
I do actually.
I did a vaginal. 15 years ago was my last vaginal hyst.
Tom and I would be happy
I'm beyond
to teach
teaching.
you.
I'm beyond teaching.
Well, they're technically TLHs because we get the uterines and all that from above, so that's technically what
that is, but I just do vaginal. Okay, all right, keep
Yeah.
going. This is my other
We're gonna
point.
move on.
Let's,
My time is getting.
yeah, your
less.
time, 7 seconds. No, you have longer than that, don't worry. It's okay, because we have another 5 minutes, and then we have 20 minutes of discussion.
All right.
We'll be fine.
We're gonna
But
move on.
this is important.
Frontline therapy. So can we improve frontline therapy? So we know that there's theoretically synergy utilizing chemoradiation and a checkpoint inhibitor, and that's related to increase in tumor antigen release, its increase in the STING pathway, and potentially modulating the tumor microenvironment. And there were 2 trials that have looked at this, the CALA trial and Keynote A18. Both frontline trials, CALA with Durva and Keynote A18 with pembrolizumab. And the CALA trial reported out, and you can see here that it did not meet its primary endpoint of progression-free survival. Now, the Keynote A18 trial, we are still awaiting the data. There are some differences between the 2 trials, but if this trial is also not positive, I think we need to think about ways that we can really sequence our immunotherapy and chemoradiation therapy. And these are 2 smaller trials that were presented at our recent meetings. This first one is Dr. Zamarin's trial, NRG GY018. And the question is really, how does differential sequencing of radiation and checkpoint blockade in cervical cancer impact the immune response and therapeutic efficacy? And in this trial, patients in Arm A received atezolizumab before chemoradiation, and in Arm B, they received atezolizumab with chemoradiation. And what they found was that when they looked at the immune activation, they found that in Arm A, where the neoadjuvant atezolizumab was given, they saw a larger fraction of tumor-associated T cell clones. Another trial, the Calibri trial that was presented at ASCO by Dr. Ray Cocord, also showed that neoadjuvant IPI and NIVO significantly increased tumor-associated immune activation based on this preclinical, based on this immune signature of CD8 and FOXP3, which was its primary endpoint. So I think this really challenges us and makes us think about how can we, design our next frontline trial in cervical cancer. And, it may be that we need to, do some neoadjuvant immunotherapy prior to starting our chemotherapy and radiation, so that we are able to do the immune education and see a benefit. I'm going to move on to first-line recurrent advanced cervical cancer and beyond. So Dr. Monk presented the final overall survival results from Keynote 826. And you all know that Keynote 826 was a phase 3 trial that looked at the addition of pembrolizumab to the paclitaxel cisplatin or carboplatin backbone and bevacizumab at the discretion of the provider. And these were the initial interim analysis 1, had dual primary endpoints, both PFS and OS showed benefit with hazard ratios that were 0.62 and 0.64 in the PDL1 greater than 1 population. And these are the final PFS and OS curves. And you can see again, the hazard ratio was 0.58 and 46% of patients that received the pembrolizumab were progression-free at 12 months. And in the overall survival, you can see that there was a 12-month overall survival benefit. So clearly, really impressive. Now, I think we can't talk about cervical cancer and not talk about one of, tisotumab vedotin. This drug was FDA received accelerated approval in September of 2021 for recurrent metastatic cervical cancer after platinum-based therapy based on Dr. Coleman's study that showed a 24% response rate. The confirmatory trial, TV301, is now completed accrual in the same setting. But can we use tisotumab vedotin in earlier lines? And you can see these are preliminary data looking at the combination of TV and pembro, combination of TV and carboplatin that showed efficacy with these combinations. And so I think the question remains whether we can replace chemotherapy like paclitaxel with TV in the frontline setting, in the first line setting, I should say. So I'd like to just move, everyone's heard about trastuzumab deruxtecan in HER2-expressing solid tumors. I want to just focus on the cervical cancer cohort of 40 patients, and the objective response rate was 50%. And again, that median duration of response was long, 9.8 months. And when you look at, again, on the left here, when you look at the objective response rate with the +3, it was 75%. In the +2, it was 40%. And when you look at all, regardless of biomarker status, it was 50%. So clearly another very, very exciting area to further explore. And I want to leave you all with.
Bhavana, before we do that, because we do have time, we built in more time into the discussion, so I think we're okay. Can we just, I think a really important point I want to go to is Keynote 826. Something I hear clinically all the time is, do we have to add Bev to this regimen for everyone? Because there's 4 drugs. So Tom, what do you do in your practice for these patients with advanced and recurrent cervical cancer?
Yeah, I can answer this probably more from an emotive standpoint than I can from a data standpoint. And we know approximately 60% of the patients receive Bev in 826, but for me, I guess it still sticks in my brain the number of young women I've lost with kids and that in cervical cancer. Once it recurs, rarely do good things turn out in long term. So for me, I try to throw everything at them. They're young, they can usually withstand it, so I throw everything at them.
You do, got it. Unless they can't get Bev, you're going to treat with it. Okay, Dave, go ahead.
But it's not just emotional. I mean, we have that emotion of that, exactly what you said. Young patients, many of them underserved. Many of them have not been, have had opportunities to participate in the healthcare. But when we look at the effect, it's additive. You're adding on IO therapy, and you're adding on Bev to the chemotherapy, going back to our original Bev trials, and giving those patients the best chance to improve their symptoms and hopefully control their disease.
GOG 240 plus. Mm-hmm. Yep.
Yeah.
Mm-hmm. And then the other one I go to is I'm going to call it trastuzumab D. I mean, this is really impressive, and it's even in that IHC 3+ group, 75% response rate, which honestly never seen that in cervical cancer. That's just a huge wow moment. So Katie, we were talking about this a little bit earlier. What percentage of patients with cervical cancer will have high HER2 expression?
Yeah, this is very much like what we're doing in endometrial. It's not just a cervix cancer question anymore, it's histology and HPV association. We're finally getting to that point. So overall, it's probably only about 7%. The TCGA would give you about 17% with amplification. But if you look particularly at your adenocarcinomas and then some of your rarer subtypes, it can be as high as 42%. So the message, and that's just, we don't test. So that's just of the people who've been tested. So the message is going to be just like endometrial, we're going to start testing broadly and finding these patients. But I think it's probably between 17 and 40% of adenos.
Yeah, I'm just blown away because in this past very short period of time, past year, we have practice-changing studies across all these different cancers: endometrial cancer, ovarian cancer, cervical cancer. I mean, it's not even been a year yet. It's like less than 6 months. So this is just really exciting information. And I'm going to let Bhavana continue because she's also going to talk about something that I think we're all very passionate about.
Yeah, I don't want to take too long.
No, you're fine.
But I do, this is an area that I'm very passionate about, and I also am the Director of Diversity and Health Equity for clinical trials, so an area that I'm really, really committed to. And I wanted to just highlight the importance of disaggregating ethnicity and race, and this is just an example. This is an NCDB database study, so it's just a start, but this, along with another abstract that were presented, did show that there were differences in outcomes, especially with the Native American Pacific Islander patients who had worse outcome in cervical cancer. And it also showed that these different subpopulations had different needs in terms of access to brachytherapy and different, so breaking down these subpopulations is really important. So what we need to do is first start collecting this information as we do our trials, and so keeping in mind that, every Asian patient is not the same, every, Latin patient is not the same. So this is just one aspect of diversity and equity that I wanted to highlight. Thank you.
And thank you for that. And I think it's so important for you to bring that up because Juneteenth is right around the corner. And so as we celebrate Juneteenth, it just gives us an opportunity to think about IDEA, which is inclusion, diversity, equity, and access to care for all. And a big part of that access is making sure our patients get access to clinical trials. So thank you. I want to invite Brad back up to the podium with me.
That's great.
And